So next up, we have a presentation from Jill Yersak, Reducing ALS Time to Diagnosis.
Everyone, I'm coming to you live from Philadelphia, which is New Jersey. I live in New Jersey, outside of Philadelphia. So nice to see everyone. I wish we could all be in person, but it's a great opportunity to talk to you guys today. So I'm really happy to share our experiences at the ALS Association around our work on reducing time to diagnosis. Our work around time to diagnosis began really through the work of our ALS Roundtable program. And back when we started in March 2019, we held our first roundtable to lay out the strategic priorities and programs of the association for the next 3 to 5 years. And after that great discussion, the number one priority that surfaced at the end of everything was reducing time to diagnosis. So today I'm really happy to go through what we discussed at the roundtable meetings and the work we've done since then. Next slide, please. Okay, so first I'm going to go through reducing time to diagnosis. And as everyone knows on this call, that this is a really complex problem. I'm not a clinician, but I've heard over the years and observed in the clinic when I used to volunteer, and from many patient advocates and friends I've made throughout the years, that many patients go from doctor to doctor for over a year until they finally get diagnosed. And this slide really shows the pathways, the many pathways people can take to get their diagnosis. And you can see that some people even seek second or third opinions before they're convinced that it's definitive ALS. And along the way, some people receive alternative diagnoses like the ones I've listed here, and some can be really painful, like spinal surgery or other horror stories that I've heard. And all these causes high stress and anxiety for the patients and their family, which is really difficult. And my point here, and I want to continue to talk about, is that we can do so much better. And really our goal is to make the pathway to diagnosis as quick and least stressful as possible. And then patients with ALS can really start receiving great care, any approved treatments that are on the market, medications for symptom management. We can start rehab, counseling, plan for the future. And then it also gives them extra time to decide if they want to enroll in a clinical trial or study. Next slide, please. So keeping all this in mind, let's move on to how we want to start thinking about solving this problem. And when we talked about this before with our roundtable, there were some of these key questions to consider. So what does success look like? How can we track progress? What are the major barriers? And who are the key players and stakeholders? What can the government, the private sector, and the association do? And how can patients and caregivers help us along the way? Next slide. So we started posing these same questions during a roundtable meeting this past spring, and we came up with a starting list of challenges to reducing time to diagnosis and some potential solutions, which I'm going to go over now. I'm going to start with challenges within the system, meaning the realm of the hospital system, physicians, and also thinking about it from a patient perspective. So first, I want to start with the fact that ALS is considered a rare disease. Given this, we need to be mindful about the potential broad education campaigns for ALS. There's a balance of people thinking they have ALS when they do not, which could really cause many false positives versus people who actually have ALS. So with that in mind, excuse me, we need to consider the number of people we would need to educate to change their behaviors before one person is diagnosed sooner. Second, for physicians, there could be a lack of awareness and training of how to recognize and diagnose ALS. There's also a possibility that some physicians, even some neurologists, may hesitate or resist making a diagnosis for the fear of being wrong, or even being right and having to deliver the bad news, which is always terrible. Third, there's a general lack of awareness from the patient perspective. Some people have gone their whole lives and never heard of ALS or met anyone with ALS until they're diagnosed. That's really scary. And or if they've heard of ALS, but they may have confused it with different similar neurodegenerative diseases. Next slide, please. We also have to consider the psychology of people with ALS. Many people are in denial or have fear, preventing them from seeing the doctor, or choose to see second or third opinions for diagnosis, leading to delays. And sometimes, and generally, it just takes a person a long time to see the doctor because generally they hate going to the doctor, and they only give in when their symptoms get severe enough. Lastly, in this category, some people are not lucky enough to be near a big medical center like the ones on the east and west coast of the United States, and instead live in rural or poor areas. They do not have the internet or the resources to know about or get to an ALS specialist, even if they wanted to. And at a past Neil's meeting, it was fascinating because they posed a question really largely to the ALS clinician audience. And they asked, if you had influx of ALS patients at your clinic, do you have the capacity to see everybody? And some very well-known ALS clinicians at very large institutions said no. And, you know, a caveat here that I want to put out there is some of these system challenges are really for the US system, not the international community, because in the US, we have dozens of pairs in each state and thousands of different physician groups and clinics, super complex. And this extreme level of fragmentation might not be the same in other countries. I really hope it's not. And in a more centralized health system, some interventions like direct outreach to primary care doctors might be a lot easier than versus what we could do here in the US. Next slide. So, you know, I also want to touch on some of the science challenges. And, you know, one of the first things to keep in mind that there's really a lack of truly reliable method to measure and track a person's diagnostic journey. If we could diagnose early, physicians and researchers could intervene earlier, giving patients more time for treatment planning and symptom management and more. I also want to mention that it is important that our community shares the information and data around the diagnostic journey. That way we do not duplicate efforts, but we can build upon each other to learn even more. You know, lastly, in these challenges, I don't want to forget people with inherited or familial ALS. This is an area we could start to diagnose earlier now if people understand ALS runs in their family. This is important because there are a few promising gene therapies in the pipeline, which, when approved, and hopefully that's really soon, people with inherited ALS will need genetic testing to receive the new drug. And genetic counseling is something we cannot forget either, because who cares if you get a test if you don't fully understand what the test means and how the results could impact the life of you and your family. And so choosing to test is such a personal decision that we cannot take lightly. Next slide. So our challenge today, our challenge is to think hard and creatively about the challenges and potential solutions that I just posed to you. What are we missing? How can we do better? How can we touch as many people with ALS as possible to make the biggest impact? Are our solutions feasible to take on together? For example, we don't want to get too big or too expensive because, let's be honest, if that happens, nothing will get done. Next slide. So also keeping in mind, we need to think about how we can start to solve these challenges. We need to consider different audiences we can target. So for improving awareness and training of physicians, for example, do we want to target more broadly upstream in the diagnostic journey like primary care physicians, or further along the journey like an ALS specialist? Or should we focus somewhere in between? For non-provider awareness of ALS, do we want to target very broadly like the general public? This could include an opportunity to reach people who have sporadic ALS but don't know it yet, or people that have ALS in their families but do not understand the risk and are not yet diagnosed. So we have to be thoughtful about who we want to target to gain the most impact and to see if it's feasible to accomplish. Next slide. So in the roundtable this past spring, which obviously was virtual because we're in COVID, we created a master list of challenges and solutions that we discussed, noting consensus among some small working groups that we were able to establish during the day. And using this consensus framework, we surveyed the participants, asking them to prioritize the 8 challenge solution pairs outlined here on the slide that were delineated by target audiences and based on feasibility and impact. And our goal really is to help find a way to make the pathway to diagnosis as straight and short as possible, to help with the stress and anxiety of the diagnostic journey, like I've said before. Next slide. So the survey directions for the challenge solution pair were for respondents to prioritize them through twin lenses of impact and feasibility. Impact in this context is used to mean the outcome will positively affect the most people with ALS and their families possible, and feasibility was used to mean the ability of the association and its partners to accomplish a goal in a set amount of time. When we thought about feasibility, we kept in mind that ALS is considered a rare disease. And so here's a summary of the survey ranking results. So the top 4 challenges based on the total score were selected for focused discussion during day 2 of that meeting back in March. So the top priorities were, number 1, as you can see, for general neurologists, lack of awareness and training and resistance to make a diagnosis. And this got number 1 across the board for both impact and feasibility. So this shows that collectively the group felt like that this could be about both something we could accomplish and we could have a great impact on at the same time. Second, for people with ALS, inherited ALS came in second. This shows that this group collectively thought that targeting the most specific population of people who could be diagnosed with ALS, those with ALS and their families, is a population we could easily focus on. Third came in was the lack of genetic testing and counseling for people with inherited ALS. And this is interesting because there are a few promising gene therapies in the pipeline, like I said, that when approved and hopefully soon, people with inherited ALS will need genetic testing to receive the new drug along with genetic counseling. So I thought, and to be honest, during the discussion that day, this didn't come up a lot, but came up really high in our survey, which was fascinating. The last top priority that came up was limited access to ALS specialists. And here participants discussed disparities in geography, age, socioeconomic status, genetics, the capacity of ALS clinics, and we spoke that it should not depend on luck or privilege or who you know to shorten the speed of the diagnostic journey. And during that roundtable, we heard from several people with ALS talking about the diagnostic journey, and almost all of them said this thing, like, you shouldn't have to be special or have luck or privilege in order to have a good pathway to diagnosis. So as far as capacity, it was also mentioned that we need a mechanism to see a larger number of people by experts, with the expectation that many of those may not actually have ALS, but those that do can get the care they need really quickly. And at the other end of the spectrum, I want to point out that the lack of awareness and training for primary care physicians was high. For impact score is actually number 2, but its feasibility score was the lowest, putting it into the bottom 2 for the total score. And, thinking about this and discussing this with the group, it's probably due to the large size of this population, especially in the United States, and the challenges to reach them all effectively are really high. Next slide, please. So from all this work, we decided as a follow-up to the spring roundtable, we'd form working groups focused on key solutions to reduce time to diagnosis, really to take forward the priority ideas identified through the roundtable discussions and moving them forward really into the action of the ALS community. Because you can talk and talk and talk, but we want to take that work and what we learned and really move it forward. So we formed these 2 working groups up in the slide, and each working group is composed of subject matter experts like clinicians and researchers. We have genetic counselors on there, representatives from our corporate industry sponsors, and most importantly, representation from our patient and caregiver community, which always gives us a really great perspective of where we should be going. And I want to also mention that Kathy Cummings from the International Alliance also joins these meetings. We talked, and we share a lot of common goals, and we know that we can learn a lot from each other, so I'm always happy to have her join our calls. Next slide. Please, thank you. So for the time to diagnosis working group, we've been developing strong messaging aimed at general neurologists about the benefits of timely diagnosis. And the narrative that is being refined by this group can be developed into a variety of formats, like infographics, videos, and written pieces. And we want to distribute this broadly using not only at the association, but with our partners all over the world. And I hope this message can be useful for reaching out to other stakeholders, including other providers that see people with ALS throughout their diagnostic journey. And a key message I want to point out that we've been talking about is that there are multiple benefits of timely diagnosis. And we want to develop a way to trigger general neurologists and eventually other providers to refer any patient with suspected ALS to an ALS center. And to that end, we're evaluating existing red flag tools to redefine them and for use really for general neurologists and other providers. And we're actually starting with the red flag tool developed by the MNDA based in the UK. We're also emphasizing the importance of triaging those patients when they come into this ALS center to be seen within 2 weeks of referral. And from our clinicians on this working group, that's relatively common. Finally, we have incorporated several questions on this year's annual report survey of the association's certified ALS treatment centers about time to diagnosis that will help create a baseline, really, or a snapshot of the current situation from which we can measure our progress in the coming years. And data from that will be coming soon. Next slide. So for the genetic testing and counseling work group, we've been focusing on the need to develop consistent and understandable terminology for describing ALS genetics, like sporadic ALS and familial ALS, especially in the light of expanding knowledge of genetic underpinnings of the disease. And for the non-scientists of the world, genetics is tough, even for scientists of the world. So we want to make this easy for people to understand. And the working group has been developing a glossary of terms that could be useful for healthcare providers. And really, the biggest target audience I see is also people living with ALS and their caregivers, so they understand. And this content within the glossary can be used in a variety of stakeholders, again, in a variety of settings. And we're really right now discussing how we can get this information out on those opportunities within our partner network. Finally, we're also have included several questions on this topic within, again, the 2020 annual report survey of the ALS Association Certified Treatment Centers. Again, to understand what the current landscape is, to set a baseline. So as we move forward, we can see whether what we're doing is making a difference or not. Next slide, please. So again, I just thank you so much. I'm honored to be a part of this day. I was so happy when Kathy and her team asked me to come and to present. And please, this is my contact email. Please feel free to contact me. And, I hope, I'm happy to take questions now and would love to hear your feedback now, but also love for you to hear from you in the future. And as we move forward, I'll probably be contacting some of you to hear your best practices, what you've done around reducing time to diagnosis all over the world. So thank you so much, and I'm happy to take questions.
Thank you, Jill, for ending us on such a terrific note, actually a very hopeful note. Thank you for that. Early diagnosis is a really important topic to tackle. We've known this for a long time. And so in looking at your presentation, I see you've done a great job in identifying the roadblocks to efficient diagnosis, and you've formed these terrific working groups. So you're on a great start. I'm curious as to your timeline to help eliminate these roadblocks. So I'm wondering, at what point do you predict we can begin to measure success in reducing time to diagnosis?
That's a really good question, and also a really hard question to answer. Giving timelines is really tough. You know that. I think, so I don't want to give you an exact answer, but my hope is that the work we're starting to do in our time to diagnosis and genetic testing counseling working groups, that we can get that out soon in the first quarter of next year. And then some of that, I'm hoping that the education material that we're developing will help start making a difference right away. And then by this time next year, when we put out another certified treatment center survey, or we survey patients and caregivers maybe through our ALS Focus survey program, we can start seeing a change in and hopefully an uptake in education understanding around diagnosis, and hopefully even seeing from our patients, this is my biggest hope, is that they are able, the newly diagnosed are telling us, instead of those horror stories, but that they're actually, the experiences are much better and more straight and much less time. So that's my hope. And, I'm happy to keep everyone posted.
Thank you. I see a lot of comments. I'm looking for a question here in the chat. There was a question as to whether you're working with the National Society of Genetic Counselors.
That's a great question. So our the 3 genetic counselors I'm working with are part of that, and they are on my list of people to contact once we have all the information ready to go. So yes, but not yet.
And I'm going to offer just a personal comment. One of the things we've done the last couple of years in Chicago is we've created a CME clinical conference for providers. And so we get not only general neurologists, but we'll get some other specialists, ENTs, et cetera. We'll also get all the allied health professionals, because you might have a PT and OT who's treating someone and not realize that it's ALS, MND.
Exactly.
So to the extent that you're able to do something along those lines, we have found it to be really beneficial.
I love that, and that's what I hope too, is to be a part of some of those types of those CMA credit courses and days. We want to be able to reach. When we were doing all this work, we came up with a general neurologist because it was easier to target, right? Because there's less of them. But I'm hoping that what we develop can reach the PT and OT community and the speech pathologists and the primary care, which I think is going to be a beast. But if we have good material and we can forge some great partnerships, I really think we can start reaching those people more effectively.
Well, I think it's terrific. We look forward to hearing more next year. Thank you so much.
Thank you so much, and thank you. Nice seeing everyone virtually. Take care.